the Data Science Unit at the George and Fay Yee Center of Healthcare Innovation. She is adjunct professor at the School of Public Health and in the Department of Community Health and Epidemiology at this university, and leader of the Canadian Foundations for Information-Funded Population Health Data Laboratory housed at the University of Saskatchewan. Dr. Leaks is a biostatistician whose areas of research expertise include, among others, health services research, methodology, and statistical methods for evaluating the quality of administrative health databases. She's currently leading a 3-year Canadian Institute for Health Research funded project to conduct comparative investigations of the quality of physicians' billing claims from Newfoundland and Labrador, Nova Scotia, Manitoba, and Saskatchewan. Dr. Leaks is strongly committed to graduate student training. She's currently the University of Saskatchewan Site Director for the WRTC to support graduate student training in applied health services research. Today, Dr. Leaks will be describing her experience with 2 data linkage projects in Saskatchewan and Manitoba and their relevance for healthcare quality at the different healthcare levels. So please join me in welcoming Dr. Leaks.
Great. Thanks, Sylvia. Thanks a lot. Okay. Well, the advantage of being the WRTC site director is that you can do a seminar, invite yourself to do it. So thanks, everyone. It's so great to see so many people from so many different areas joining us today for the WRTC seminar series. So I have a really unique perspective in having worked with very large healthcare databases in many different provinces, but particularly in Manitoba and Saskatchewan. And so I want to talk about that experience today. So what I'm going to do in the next about 45 minutes is talk about data linkage and why it is such a popular topic right now, why there is an explosion really in terms of data linkage centers, both in Canada and abroad. And then I'm going to talk about 4 different projects that are at different stages of development using data from Saskatchewan and Manitoba. The first one is a project completed just this year that's looking at laboratory data, and I'll talk a little bit about the quality of the data and the scope of using laboratory data for population health and health services research. The second is a really unique project using Saskatchewan's data that focuses on looking at trajectories of people's movement through the healthcare system. The next one looking at rare events in particularly in vulnerable populations. I'm going to be talking about how we can use linked administrative databases to look at chronic conditions in pediatric populations. And then the last, which is an area where there's an incredible amount of growth right now in terms of research, focuses on risk prediction, particularly for chronic health conditions, and why these are important tools for decision making and what they can contribute to the healthcare system. And then I'll conclude by talking about challenges and opportunities for data linkage. My motivation in part for talking about this topic today stems from the fact that the International Health Data Linkage Network, which is a network of centers that link secondary data sources around the world, is very active at this point in time. The network started probably about 5 years ago and had hosted one conference on this topic in Australia a couple of years ago, which was a fantastic opportunity. They're going to be back here in Canada, in Vancouver actually, in spring of 2014, and the deadline for abstract submissions just opened. This is a conference that's very relevant for many Canadian researchers who are working with linked databases. And so when we talk about data linkage, what we're talking about is connecting pieces of information, usually in population-based administrative health databases. So these are databases that were designed for administering and monitoring the healthcare system, not originally intended for research, but are now being used for very innovative research projects. And the linkage can occur across different data sets in one domain, for example, linking hospitalization records to records that come from contacts with physicians when you go and visit a physician, to contacts from going to the emergency room, the emergency department, to contacts that happen when someone ends up in long-term care later in life. But increasingly also there's interest in linkages across domains. And that arises because we know that health is influenced by much more than just health care. Certainly it's influenced by education, by the environment, and increasingly a life course perspective that recognizes the impact that early childhood development has on health and health outcomes later in life is a reason that there's a lot of interest in data linkage and also in the network that has formed. In Canada, there are centers that work with secondary data sources to link them together in order to do population health and health services research in every province. And there's also work that's ongoing in the territories because I've been involved with that. So going from west coast to east coast, you'll see the listing of centers, those that are here in the prairies. So the Health Quality Council, and there are a number of people who've joined us today from the Health Quality Council, welcome, is a hub of data linkage activity here in Saskatchewan with a mandate to focus on improving the overall looking at the quality of the healthcare system. And I've worked extensively with people there. And in Manitoba, the Manitoba Centre for Health Policy, which is one of the oldest data linkage centres in Canada, based at the University of Manitoba, has a slightly different focus from the Saskatchewan site, does focus much more on that intersectoral relationships in terms of data linkage to be able to understand the determinants of health. Some of the newest ones, the Newfoundland and Labrador Centre for Healthcare Innovation. I'm working with researchers there right now. It's a brand new data linkage center, but they're doing just a great volume of research and some really innovative stuff focusing on healthcare databases in Newfoundland. And we can't ignore what's happening at a national level. Statistics Canada, and through its research data centers, of which there is one here at the University of Saskatchewan, is emphasizing opportunities for data linkage. For example, national health survey data can be linked now to other kinds of data sources, including hospitals. And here has been doing some great work with that and has projects involved in linking survey data with other administrative data sources here in Saskatchewan. So that's a unique opportunity and has been facilitated by work that has gone on in Statistics Canada. Internationally, the hotbeds of data linkage activity occur in Australia as well as in New Zealand and several European countries. And here's a smattering of them. In Manitoba, we've had quite a bit of connection with Western Australia and the data linkage work that they've been doing, which is phenomenal. And the United Kingdom as well. The Oxford Record Linkage Study is a very long, ongoing study that links a number of different data sources in order to be able to primarily focus on population health. And one that's just recently started is in Wales, the SAIL Data Bank. And it's part of an initiative that's just been funded around data linkage in the UK. There's right now, part of the interest in data linkage is that there's a lot of money being invested in doing data linkage projects. The Medical Research Council in the UK set up a consortium to fund 4 research centers, these health informatics research centers, of which SAIL, the center that's located in Wales, is one of them. The investment is astounding. So more than 17 million pounds over 5 years, focusing on linking of different secondary data sources in order to be able to understand population health and health, and health services use, and also to build capacity just in doing health informatics research. So this is an indication of the interest that's occurring not only in Canada, but worldwide in terms of linking different databases. And so why does that happen specifically? And this is a picture of what goes on in Manitoba at the Manitoba Centre for Health Policy in terms of the kinds of databases that are available. and in turn, the opportunities that exist for doing a diversity of research projects. At the core is a person registry. So it's a registry of everyone who receives health services. And you know that in Canada, we have universal health care, so that essentially covers the whole population. And in Manitoba, that goes back to 1970. So we have now more than 40 years of data being able to follow individuals longitudinally. And just a diversity of different kinds of data coming from many different domains that can be linked together in order to understand population health and health services use. The interest in doing data linkage comes from a number of different pressures. Part of it are the challenges of doing primary data collection. I had an email not too long ago from people at Statistics Canada who are doing the Canadian Community Health Survey, which is a national health survey that collects information on determinants of health, health service use, and population health. And there are challenges associated with continuing to try to collect the survey data over time. People are not as interested in participating in surveys as they once might have been. So there are a lot of challenges in terms of doing primary data collection and then thinking about how that data can actually represent well the population that it's intended to reflect. With linking many different kinds of administrative databases that do in fact cover the population, you can have a representative sample and generalizable information that does reflect what's going on in the population. Another pressure that comes is the recognition that clinical trials really are very limited in the information that they can provide. One very large interjurisdictional project that's going on right now is looking at drug safety and effectiveness using linked databases. And it stems from the recognition that clinical trials usually focus on such limited populations that have very specific characteristics, usually are very healthy, and only occur for a very set period of time. Hence, we can't understand the long-term effects of drugs if we're not looking at them in real-world populations and over long periods of time. Linked databases provide that opportunity. Also, there is an increasing technical capability to work with very large data sets, massive data sets, and to be able to extract useful information from them. And conduct a variety of different environments. And then the last piece, as you well know, that governments are under increasing pressure to be accountable and have limited budgets for healthcare. And so how do you target that limited funding in order to achieve optimal results? So increasingly questions are coming about what kinds of exposures or conditions are important antecedents of poor health outcomes, and what programs might work in the most cost-effective manner. So by linking different databases together, for example, databases about participants in a particular program to information on health outcomes, it's really possible to be able to understand what works and what doesn't work. The interest comes also from being able to look at rare conditions or rare events. So I'll talk about pediatric populations in that respect. Recognizing the intersectoral nature of many health problems that we face, and also the life course perspective, and recognizing that understanding the environments and exposures that individuals have throughout the life course, including in early childhood, and even before that, in the prenatal period, can have a significant impact on health later in life. By linking data together across time, and even maternal data with later childhood data and young adult data, it's possible to understand those antecedents of poor health outcomes in adults in older age that might stem from what kinds of exposures have occurred early in life. Okay, so with that, I'm going to talk about a number of different projects that illustrate some of the things that I've talked about here, and then I'll do some summation at the end. So the first piece that I'm going to talk about is a study that I completed just in December that was looking at the population laboratory data in Manitoba. So Manitoba Health had commissioned the Manitoba Centre for Health Policy to bring in an archived data set from the Chatham Provincial Laboratory there. And there was a massive amount of data, probably about 12 million records that came in. I don't know how many actual data sets there were, probably verging on close to 1,000 of them. These data are unique in that they capture all population-based infectious disease tests, so notifiable diseases. These would include all sorts of sexually transmitted diseases, foodborne illnesses, for example. This wealth of information on notifiable infectious diseases that extends all the way back to 1992. And the Chatham Provincial Laboratory was moving to a new health information system. So they had all of this archive data, and they said, well, what can we do with it? And so it was viewed as a prime opportunity to bring it in and link it with other administrative data sources to enhance our ability to do population health and health services research, and particularly focusing on risky populations. So you think about populations that may have HIV/AIDS, or that have high rates of STDs, for example, presents a prime opportunity to look at the data. And so the focus of the project was twofold. First of all, it was to describe the quality of the data, and second, it was to examine how these data could be used to study health and healthcare use in Manitoba. So I'm going to show you a few select results in terms of what we found. So when we linked the laboratory data to other kinds of data sources, it allowed us, first of all, to look at how utilization or testing might differ between different income groups in the population. And we were pleasantly surprised to find that people who were in the lowest socioeconomic groups in Manitoba actually had higher rates of testing than individuals who were in higher income groups, which was logical. It made sense when we were looking at the data from a quality perspective. And also it was reassuring to see that the healthcare system is performing well in terms of where testing needs to occur, because riskier behaviors are more likely to be overrepresented in lower income groups than in higher income groups, that was actually reflecting what was happening in the data. And that was an enduring trend over time. Another thing that we were interested in looking at in the data was the prenatal population. So testing for certain kinds of infectious notifiable diseases is supposed to be routine in prenatal population. So with rubella and hepatitis B, there's supposed to be standard testing that occurs over time in all women when they discover that they're pregnant. And what we found was that when we look over time for those notifiable conditions, we see really high rates of testing in the population, which again is a good news story. So by linking the data, we were first of all able to identify people who were expecting a baby, so we were able to identify those who would be recognized as prenatal, and then look at whether or not they'd had these particular tests that are required in Manitoba. And then we could add in other kinds of tests where there's a changing pattern. So hepatitis C, for example, isn't required testing for all pregnant women in Manitoba, but you can see that there's an increasing trend in recognition of the fact that this is a condition that could have serious implications for the child and possibly later in life. And so there is testing that's going on, and that's increasing over time. So data linkage enabled us to look at this within the prenatal population. But we also recognized that when you're looking at administrative data, the quality issues can be substantial. What we have here are data from 3 health regions, Winnipeg Regional Health Authority, the major health region in Manitoba, and then 2 areas, 2 health regions that are in the western part of the province, Brandon and Assiniboine health region. What you can see is that we get some fairly major changes in terms of the trend in testing, the proportion of the the percent of the population that has at least one test. What this told us was that we may not have all of the data that represents the entire population. And in fact, there's a laboratory site in Brandon. and we're missing some of the data. So a next phase of the project is actually try to be more comprehensive. So we thought we would have virtually all of the data by bringing in that CADM Provincial Laboratory Archive data, but we discovered that there were, in particular, geographic gaps in the data. So with any record linkage project, you do need to be critical and say, does it cover the population? Does that happen over time? And what administrative factors might impinge on our ability to have comprehensive population coverage? Then the last picture that I'm going to show here, we're particularly interested in HIV tests as well, identifying people who may have had an HIV test and look at their health outcomes over time. But there was a major shift in the identifiability of the data over time that impinges on our ability to look closely at who might have had an HIV test, recognizing always, though, that we're working in a confidential health environment. So the personal health identification number, which is the linkage key in virtually all provinces, you have a unique health number. That's how different databases can be linked together in data linkage centers across Canada. It was essentially anonymized, non-usable, until a major shift in policy that occurred just at the end of the data collection period that we have information for. So our ability to look at individuals long-term who have had HIV tests, again, is impaired. We can do that in the last few years of data that are available, but not prior to that. Again, a recognition for us that administrative data have lumps and bumps in them, and you do need to be cautious about saying that you can study any health problem when you work with these data. All right, so that's the first of the projects that I want to talk about. The second is a project that's ongoing in Saskatchewan with colleagues at the Health Quality Council that is focused on linking together different databases in order to understand the trajectory of individuals through the healthcare system. This idea of episodes of care really emerged from the US in the 1960s. And what an episode of care is, it's a series of related healthcare services that might be related to a particular illness or a healthcare event. Something like if someone breaks a hip, for example, you might want to look at how people move through the healthcare system. And this idea of focusing on healthcare, not around the delivery of a specific service, but instead around the patient, is something that's gaining increasing interest right now as we think about our healthcare system to patient-oriented. So understanding how move through the healthcare system, how long they might spend in particular areas of contact, the sequence of contacts with different components of the healthcare system is important for providing patient-oriented care, but it actually grew out of an interest in the US in how to remunerate different healthcare providers. And the emphasis at the time was on remunerating around the event as opposed to the actual delivery of service, with the idea being that if you remunerate around the event, you're rewarding better, seamless care. So our interest has been doing this in Saskatchewan. So let me just walk you through an example of how you look at an episode of healthcare using linked databases. So the structure of any episode of care is that there's an initiating event. So I'll talk a little bit about that. We're doing this around chronic obstructive pulmonary disease, which is a chronic disease that has respiratory implications. So if someone were to end up in hospital or seeing their family physician for a respiratory-related illness, that could start off an episode of care. And then you're looking for events that occur fairly close in time. So if there's a major break in when someone last has contact with the healthcare system, you view that as really being the end. So we talk about a clean period, and usually being 30 days at least in length, because if you haven't seen some kind of healthcare provider for a month around a particular condition, it's very likely that it's going to be starting off another healthcare episode. So it's linking together, looking at the time frame between these and looking at very different kinds of healthcare services that may be provided, but that we can link together to look at how someone moves through the healthcare system. And so in Saskatchewan, for example, we've got a wealth of data that do span the continuum of care, from emergency department data to the acute care environment, so within hospitals, the primary care environment, and then supportive care. That would include long-term care and home care. Plus, there's the ability to pull in things like prescription medications that may be used to treat particular kinds of conditions and procedures that may occur in hospital or in outpatient settings. And by linking all of that, we can understand how people receive health care and how they do move through the healthcare system. And we've been interested in this for patients with chronic conditions, such as COPD, because they're resource intensive. If someone ends up, for example, in hospital because of their COPD, that might be potentially avoidable and better managed through the primary care system. Often individuals who have chronic conditions have complex healthcare needs and may be contacting a number of different providers. And it's important to understand how these people may be moving through the healthcare system and where they may be lost to follow up. And also, for many chronic conditions, we can define those conditions easily using administrative healthcare databases. So I'm going to talk a little bit about a project that we've presented on before that's looking at care for COPD exacerbations, and particularly looking at recurrent events. So one of the things that we've done is say, well, it's unlikely that someone's just going to have a single episode of care for COPD. What's the time frame between them? What do they look like? What are the patient characteristics and the episode characteristics that may be associated with the frequency with which someone contacts the healthcare system for an episode of care? And so we've linked together the databases that are identified on the top. The Health Quality Council, where we're doing this work, has recently been able to acquire emergency department records from both the Saskatoon and Regina-Qu'Appelle health regions in order to expand our ability to explore these episodes of care. So some information here in terms of the distribution of time to recurrent events. So what we found when we looked at someone who'd had a first COPD exacerbation episode of care and the time to the next one, so the median time was around 460 days, so a little over a year, but highly skewed distribution. Many people having a shorter period of time from one episode of care to the next one. And then when we looked at the difference between people who might have contacted the healthcare system either via hospitalization, physician visit, we showed how you might have initiated an episode of care for COPD and the length of time to a subsequent episode of care. And then the last piece, so the hazard ratios here indicate, so for hospitalization, that there's a shorter time to a subsequent event if you first had a hospitalization initiating your episode of care than if it was a physician visit, possibly reflecting the fact that people who end up in hospital for their COPD may in fact just have, they may be more complex patients, they may be older. But after we did adjustment for the fact that there may be comorbidity confounding that association, you'll see that we still have a fairly high hazards ratio when we look at that. And a number of different characteristics, as one might expect, factors such as age and when your COPD was diagnosed that are associated with how long between different episodes of care for COPD exacerbations. All right, so I'm going to move on now and talk about the next data linkage project This is one that's occurring in Manitoba, and it's focusing on chronic conditions in pediatric populations. And the advantage of using linked data that it's possible to look at the longitudinal record for individuals, as I've mentioned, that could extend right from birth into early adulthood. The particular condition that we're interested in is arthritis in pediatric populations, which is a fairly rare event. So these are the number of cases per 10,000 population. So you can see in Saskatchewan for males, about 6 in every 10,000 males who are under 18 years of age have inflammatory arthritis. It's slightly higher for females. You can see in both Manitoba and Saskatchewan that it's around 10 to 16 individuals, but still per 10,000 population that would have this. Fairly rare condition, but one that has significant implications for later life. The pain, as you would expect, associated with inflammatory arthritis can be substantial, so it could impact, for example, on children's performance in school, and the requirements in terms of use of healthcare resources can be quite substantial, but has not been looked at to any great extent using linked databases. And so what we're going to be doing in Manitoba is linking data from one particular pediatric rheumatology clinic, and it's the only clinic in the province. The advantage of working with small provinces in terms of doing this research in that services tend to be quite centralized. So it's possible to connect to linked databases that capture virtually the entire provincial population, and it's no different here in Saskatchewan as well. And it has data going back to the 1970s. So we really can look at people as they move through life in terms of the impact of having arthritis on their use of healthcare resources, and possibly linking to other kinds of databases to look at impact on use of other kinds of services overall, including education. And we'll be linking that with hospital and physician records and prescription drug records in order to do our research. It's not an easy process, though. One of my messages here, and we're still actually working through the approval process. So this project, we started applying for approvals in June, and we're getting close to being ready to move forward to actually do the research. But it's a process of getting approvals from Manitoba Health, so from the Ministry of Health. There is, of course, ethics that needs to go along with that. The Winnipeg Regional Health Authority, which is the custodian of the clinic data, does need to give approval, and the data exists in a particular facility, the Health Sciences facility within the Winnipeg Health Region, and so they also have to provide approvals. Once we have all of those approvals in place, then the University of Manitoba actually has us sign a data sharing agreement in order to be able to get the data to come to the Manitoba Centre, so we'll be lucky if we're going by January. But the excitement around doing this, and that we can build an entire program of research looking at arthritis in pediatric populations by first looking at whether we can accurately identify children and youth who have inflammatory arthritis. We can then look at the impact of the disease in terms of prevalence and incidence, and then look at the implications for the health by linking different databases. All right, and the last project that I'm going to talk about, one that we're increasingly spending time on, this idea of risk prediction and developing tools for decision making using linked databases. This idea of clinical practice guidelines and being able to provide patients within the clinic setting information on how likely they are to develop particular kinds of diseases over the life course is of interest, and certainly can guide therapy and treatments that are offered to patients. And so developing a clinical prediction rule occurs in many different kinds of chronic diseases, and it's incumbent on being able to identify the optimal combinations of symptoms, diagnoses, and medical signs to predict the probability of a particular disease or outcome. And I'm going to focus on talking about this with respect to fracture risk prediction. So how likely someone is to have, in particular, an osteoporosis-related fracture. Osteoporosis is a chronic health condition that is drawing increasing attention as our population ages. Osteoporosis is actually fairly common. About 20% of individuals in the 50-plus age group have osteoporosis, and it manifests in terms of an increased risk of fractures. And there is a lot of interest in developing fracture risk prediction tools or algorithms. In particular, the World Health Organization has developed FRAX. If you've not seen it, there's the URL is here. John Canis at Sheffield, University of Sheffield, is the leader in terms of doing this. And so what FRAX is, and it focused in the European populations, but they're algorithms that give you the 10-year probability of fracture risk. And using the linked administrative databases in different provinces and territories has been useful in terms of validating these risk prediction algorithms and also trying to enhance some of the variables that we have available in order to do risk prediction. Okay. And bone mineral density is by itself a fairly good predictor of how likely you are to have a fracture later in life, but it doesn't have perfect sensitivity and specificity. And in fact, good results are emerging by looking at multiple risk factors that may affect your probability of fracture later in life. And I'm in particular going to focus on both the personal and family history, because that seems to be in some ways where we might get the most bang for our buck in terms of using administrative health databases to understand how we can build better fracture risk prediction tools. Okay? So parental hip fracture is one of the strongest clinical risk factors for osteoporotic fracture. And if you look at as people age, it's really important when you get in that 70-plus age group. But we often don't have very good information on parental hip fracture just from, for example, clinical records that might exist. So instead, if we can look at linking many different databases together, is it possible to do that? And in fact, in Manitoba, there's an increasing emphasis on this life course perspective, where initially there was a lot of focus on the individual and just their own healthcare files. But with data linkage, it's actually possible to look at the family unit and hence to be able to identify individuals who are in the family, and also many different kinds of linked databases to better understand that life course perspective and how it may impact on disease over time. Okay? So in this individual registry, there's both an individual and a family identifier, so that it's possible to connect each person to both past and current family members. So you can identify the family unit. And then you can look at longitudinal information about these related individuals. So you can start to tease out that family history. Where other data linkage centers are interested in incorporating things like genetic information into linked data, there's been a move instead in Manitoba to focus on how we might use that family unit identifier to do something similar. The genetic data is that it's available most is on the entire population, but with the family unit approach, you can achieve that. So other than in Newfoundland, where there's a great interest in trying to capture genetic information on the entire population, that's not happening in most other jurisdictions. So instead, how can we try to achieve that by using linked databases? Okay, and given that the Manitoba Research Registry starts back in the 1970s, and you can actually identify, going back to 1952, children and their parents in these units, you can understand how now we can actually look at people who are older, in their 70s or 80s, and understand their fracture risk and look at the outcomes. Have they actually had a fracture? And then link that to what's happening with their children. So a really unique opportunity that's presented itself through data linkage in order to be able to do this. Okay, so that's the end of the vignettes of different projects that involve data linkage. I'm just going to wrap up now before I open it for questions. So the challenges, of course, of using linked databases to understand population health and health services use. Databases are often collected for very different purposes. So the queries and the methodologies in terms of assessing quality, things like completeness of coverage of the population, consistency of coverage over time, methodologies for managing these very large databases, for ensuring they exist in secure environments, and looking at different options in terms of providing access. So in Canada, most of the data linkage centers have really existed as enclaves where you have to be on site to access linked databases. That can be somewhat exclusive in terms of capturing as many kinds of researchers as possible to engage in this kind of research. So many different centers in Canada, as well as internationally, are looking at different models to provide access to data that still ensures that these databases are secure and the information in them is secure, because data privacy and confidentiality always is an overriding consideration when data are being used for purposes other than which they were originally intended. But along with those challenges are so many opportunities ahead. I'm starting a new project in Manitoba that is taking virtually all of the data that's available through our cancer agency, including registry data, screening program data, and even medications. So prescription drugs that are provided as part of chemotherapy, for example, to cancer patients, so that we can begin to build a system that will enable cancer health services research, where prior to this, most of the research using the cancer data in Manitoba has focused on surveillance and only surveillance. So it should expand incredibly the ability to understand health outcomes, for example, and health services utilization for people who have had different kinds of cancer. As well, another project is ongoing to bring in all of in-hospital prescription drug data, where primarily we've had access to out-of-hospital data. When someone is in hospital, there are drugs prescribed, and linking those to our understanding of out-of-hospital utilization as well should expand our ability to understand drug outcomes over the long term. In Saskatchewan, I've talked about the emergency department data and its availability for things like episodes of care projects, and also different kinds of prescription medications. Those, for example, in Saskatchewan that are not on the formulary. In other words, those that are not necessarily listed as being covered by your prescription drug coverage. There are other kinds of, in many cases, very expensive drugs that would not be covered by provincial benefits, but that may be used particularly by people who have chronic health conditions. And so I know there's a move within the Health Quality Council to try to gain access to these data, because it would greatly expand our ability to look at the effect of different kinds of drug exposures over the long term and in large populations, particularly for drugs that may not be used by very many individuals. All right. So, and finally, to close off, talking about the opportunities in data linkage, it is to engage many different kinds of researchers, not just those that come from a health background, but those that come from backgrounds in nursing, in economics, to name a couple of examples, to help understand many different kinds of databases together. And also, opportunities exist in training. So with the new data science initiative that I have going at the University of Manitoba, there's recognition that skills just in computer science or just in statistics are not adequate to help us understand how to work with these very large databases. And in fact, we need people who are trained interdisciplinary in nature, who might have a substantive background, but also have skills in how to manage and monitor and work with very complex databases. And so increasingly, training programs in things like data science are beginning to pop up in Canada and elsewhere. And that was part, for example, of the initiative in the UK is focusing on training people in health informatics. Okay, so a long list of people who I work with in terms of this research. These projects are not mine. In many cases, they involve a large team of individuals who come from many different backgrounds to do this research, and as well funding from many different sources. Okay, so you can contact me if you have questions, but we'll open up the floor now to questions here and also at the University of Regina. Okay. Okay. And so Sylvia's going to moderate for us, so you decide where you're going to start. All right, great. Now we can see everyone who's at the University of Regina. Welcome. So glad that you could join us today.
I don't know if they can hear me. Can you hear me there in Regina?
Yeah.
So we are going to start with Regina.
Okay.
Do you have some questions in Regina?
I'll bring them and try and speak.
Hi, can you hear me up there?
We cannot hear you.
Is Nate?
Hi, can you hear me now?
No.
Sorry, just give us a second. We'll try to adjust the volume at this end so that we can hear.
The Regina participants might have to get up and speak to a microphone. I'm not sure if the room is outfitted.
Yes. Can you hear us now?
Try repeating your question.
So can you hear us now in Regina?
Yes.
Okay.
You're a bit faint, so if you can just speak up a bit, but yes, I can hear you.
So I think, so it's Saqib Shah from the Ministry of Health. I think you made a really important point that as databases migrate to electronic records, both in health and in other sectors like education, social services, there's lots of opportunity also for data linkage. And I guess the question was, how do you overcome issues of confidentiality and consent for databases that are going to be built into the future, where you can build that in terms of gathering the data, but also when you look at databases that already exist or are migrating from paper records to electronic, how do you address some of those issues when you go through your approval process?
So it's around confidentiality issues. Yeah, if I got that right. Okay. So how do you deal with confidentiality issues? Well, recognize that when I talk about data linkage projects here and in any location where this is occurring, that there's always the data are anonymized. So while in Manitoba, as here, there is a linkage key that exists in Manitoba Health, but there's an anonymization process, certainly with any of the data that resides in the Manitoba Centre for Health Policy, so that it's not possible to trace back to the individual. There's a justification process that does need to happen, and data access committees in all jurisdictions focus on evaluating the benefit to be gained in relation to the linkage that needs to happen. So as an example, when we look at the project that we're trying to get approvals for now on the pediatric population and looking at arthritis, children are viewed as a vulnerable population. So our project goes under increased scrutiny from a committee that includes not just researchers but members of the public to say, is there a benefit that outweighs any potential harms that come from data linkage? And so there's that constant scrutiny, and as I said, it does exist in each of the provinces to say we do need to ensure that we are making good use of the data and for benefit to public the data linkage. So that will not that's always going to be a component of the landscape around data linkage projects. Certainly, as we look at different kinds of databases coming in, when we think about things like genetics data being linked to, there will always be that ongoing debate and discussion about using these data possibly without individual permission, but in many instances when we talk about individual permission that's not practicable, or from the perspective of not identifying individuals, that would be the standard that one would want to adhere to. But I think there will always be discussion about the benefit that has to accrue from bringing these many diverse databases into a linkage center that we have assurances around confidentiality and also that there's benefit to be gained. So I hope that answers your question. We'll probably still stick with, we may stick with Regina.
Yeah, there is any other questions in Regina?
Hi, can you hear me okay?
Yes, very well, thank you.
Yes, I'm wondering if you're familiar with work that's been published by Josie Lavoie and her colleagues. It was in Social Science and Medicine, I think, a couple of years ago, and it linked data from Manitoba Health with data from the federal government, and it was specifically looking at the degree to which communities, First Nations, had control over their health services, and it showed that where there was the duration, the longer they had control, and the greater the degree of control, the better their health outcomes. But in that study, she also recognized that there was huge problems linking with federal data and interjurisdictional issues that really made the whole thing quite complex. So I just wonder if you want to comment on that, because Aboriginal health is obviously a key area where this sort of data linkage might be useful.
Yes, and there are several people in Manitoba who've been leaders in terms of that, and they will also share that perspective that when you cross jurisdictional boundaries, it can take very long periods of time in order to gain the approvals, in order to do those kinds of data linkages. There's a lot of relationship building that needs to happen also to for there to be assurances that there's going to be benefits that come from doing the linkage, as I mentioned in reference to the previous question. But you're correct. In studies around Aboriginal health, and also there's work that's been done in Manitoba, and that's also happening in other jurisdictions across Canada, looking at Métis health, for example. The recognition that health outcomes may also not be so positive in the Métis communities. This is really important, and why people persist with data linkage projects, despite the fact that getting the access permissions can be challenging. But I know that the situation in Manitoba, the work that's been done there by many individuals, has had many positive impacts just in terms of talking about delivery of health services and different kinds of programs that might be investigated or introduced in order to have positive impact in the healthcare system. And again, you can think about the challenges of doing that kind of research by collecting primary data, and hence why linkages involving secondary data sources are so important. So thank you for pointing that out. There are benefits and challenges that go along with that.
Okay, so I'm not sure if there is any other question in Regina.
I don't think so. Not
okay, so
right
we have
now.
a question over here. Do you still have a question?
Okay, so yes, you can use.
Okay, no, just simply you talked about, and I guess this follows up the confidentiality question, you talked about a shift in policy that allowed collection of the health data via the health identification number. Do you recall how long ago that occurred and what the name of that was?
Well, that's always been the case. So linkage of databases in Canada does occur by each person has a unique personal health identification number. That's not a shift. That's not a change. It's something that's always been ongoing. Now, the availability, I think you're referring back to the slide that I'd shown from the laboratory data, right, where there'd been a shift in policy around whether or not those personal health identification numbers could be linked to other databases or not. And that was very specific to the laboratory data.
Okay.
Was the laboratory itself.
Oh.
So it would be possible to do record linkage studies for individuals who have had HIV tests past, I think, 2008, 2009, that it will be possible to do that. Prior to that, there was no opportunity to link the personal health identification number. But I guess the caution that goes along with that, with the data, is that that's very sensitive information. So in Manitoba, there have not been any data linkage studies that I know of that have looked at people who've had HIV tests and linking to other health services. That would go under an incredible level of scrutiny if someone wanted to do that.
Do you recall when the shift in lab?
When I showed, I can go back to where that is. It was right before the end date where we got the archived laboratory data, where it was possible to link. Yeah, so here we go. It was this one. Yeah, so there was a shift in policy in the 2006-7 fiscal year, and so only after that time do you see a major change where you could actually uniquely identify personal health identification numbers for linkage to other databases. So there's the potential. Again, I'm not sure that there have been any data linkage projects. They would have to go through all of the permissions in order to do that. Our goal in looking at the laboratory data was to say what's possible using the data. So it was an exploratory project. Okay, thanks for the question.
We have another question.
Yeah, and you can use your mic there.
Oh, so that works. So you were talking a bit about family linkages and doing that kind of thing, which I found very interesting. And I was wondering if the way that you go about doing that is relying on the self-report of the patient, so like they tell you my mother died, or do you actually link it back to their mother's own health record?
You can link it back. So in Manitoba, and this is really Les Roos's project, so I can connect you with him, and Les is one of the founders of the Manitoba Centre for Health Policy. So what you have are records from hospital data, from physician data, and then this backbone, which is the individual registry, so the research registry. So the research registry has it has information on the entire Manitoba population that's eligible for health services, and it goes back to the 1970s. And then because there's a unique personal health number, and that number is not repeated for individuals, so once you have that health number, it's yours for life, and long beyond that, it's not repeated. And because there's also a family identifier, there's no self-report involved. It's actual records. So your information when you are eligible for health services in Manitoba, and that information is maintained over time. So yes, you can actually identify when individuals die because their coverage would stop. And then that can be linked to other records in the hospital data and in the physician data, so that you can look at the healthcare utilization and hence health outcomes for parents, and then link that to what's happening with the child.
So is that only useful for statistics, or can doctors have access to that to kind of figure out what your patient's real history is?
No, that's a good question. With any of the data that reside in the Manitoba Centre for Health Policy, so approved research projects to investigate those linkages only can access the data. So a family physician would not be able to go and look at that information to look at personal risk for the individual, but rather there's the accumulation of information in things like building these risk prediction models.
Yeah, so maintain a good relationship with your parents is the take-home message.
Well, and it's possible also, I mean, the techniques are very complex, and as I said, Les Roos, who's at the Manitoba Centre, has spent years trying to look at how to do this, and how to do it in a way that maintains the integrity of understanding who's added to the family unit, who may leave the family unit, and it's not for the faint of heart, but he's really in the last couple of years pushed it, and there are a number of projects that are using now family history data, and including one we're hoping to do with this fracture risk prediction, to get away from just relying on self-report, which may not be all that accurate. So asking, if did your mother or father ever have a hip fracture, how likely are you to actually know that? There may be a lot of self-report bias. Instead, if we can link to records, and hip fractures are pretty reliably recorded because they have a fairly major implications for the healthcare system. That's a much better way to look at family history. Thank you for your question.
Okay, so we are going to come back to Regina.
Okay, sure. And we'll follow with Mohsen.
Do you have any questions in Regina?
No questions here, no.
Okay, thank you.
Okay.
More questions here in Saskatchewan.
Can you use a mic, Mohsen? Thank you.
What are the general sources of error in the link data? I mean, for example, you have two sub-data. When you analyze your outcome, you see general trends, for example, increasing trends. But when you merge those data sets, those two in a linked data set, you see your trend is another trend. Then is there, it can be attributed to some general form of errors?
Okay, so the question.
So, what are those errors?
Yeah, so you're right, and I've pointed this out in the projects that I've moved through, that you have to take administrative data with a grain of salt because of errors in it. And there was a time when I know having discussions with other people saying, well, even with errors, the big picture is what we're interested in, and so that's what we should focus on. But there's been a major shift over time to saying, no, let's look at the error, let's document it, and let's look at how we can enhance the data to reduce the impact of errors. So one of my big interests is in diagnoses. And we know that there can be substantial misclassification bias in diagnoses, particularly for some chronic conditions. So osteoporosis is one where if you look at a diagnosis for osteoporosis, it doesn't happen very often in the data, because when you go to see your family physician, they're not likely to code osteoporosis as the reason that you saw them, versus diabetes, where the diagnostic misclassification is very minimal, because that is often a reason that you go and see your family physician. So understanding how much misclassification there is a huge topic of interest. So that's one source of error, and trying to overcome that so that you have better prediction models around who actually has diseases. The other that's eroding the databases, or there's concern that it's eroding, is actually healthcare reform. As physicians are increasingly being paid on methods other than fee-for-service, there's concern that things like physician claims databases are losing data over time, and that's, Sylvia talked about one of the projects that I have funding for right now, and it's looking at how much data loss there might be, physician activity, because physicians are more likely now to be paid a salary, particularly some kinds of physicians, as opposed to doing fee-for-service billing, which has been the predominant mode of remuneration, and one that generates the most activity in terms of administrative data. In Newfoundland, for example, a province where we're working in, physicians who are paid on salary do not need to report any of their activity through the billing claims system. And all physicians who practice outside of the major urban center of St. John's are paid on salary. So the expectation that you're losing a lot of information on those rural populations is a big concern. And one of our projects is to say, what impact does that, for example, have on our ability to do chronic disease surveillance? Those would be probably the two biggest sources: completeness of the data and diagnostic misclassification.
Okay. Do we have any other question here in Saskatchewan? Okay.
Thank you very much, Dr. Ellis, for your presentation and sharing your experiences. I would like to make a question and raise an interesting and controversial topic regarding your provincial laboratory data. You presented a really good figure where you you demonstrate that the number of laboratory increased over time. So, do you think that it's possible to evaluate the accuracy of these labs, and which might be the challenges in the scope that we are facing rising costs of the healthcare systems, and it will be nice to have this amount of data to evaluate this?
Yeah. So thanks. There are lots of challenges with the laboratory data. It's great to have all of this infectious disease testing data, but again, it's around testing. So the volume of testing has increased over time. The other piece, if you're actually trying to identify individuals, is to say, with those diagnostic tests are also changing over time, and do they change in terms of sensitivity and specificity? So there's a lot of complexities. So total volume is increasing, but the kinds of tests that are being offered is changing. What's notifiable has an impact in terms of what's in the databases, so that can be one of the reasons why there's increases. The thing to understand is accurate diagnostic tests will identify individuals with particular infectious diseases. So we've been challenged, I think, we have more questions, I think, following that particular project, looking at the laboratory data, than we have answers right now in terms of how we use it and what some of the challenges are associated with that. So I think it takes a real interdisciplinary team. We've worked a lot with the scientists at the CADM Provincial Laboratory in terms of trying to understand what's in the data and how it could be used, why we see changes, what kinds of diagnostic tests are in the data, and what the relationship too is between having a test and having a diagnosis for a condition, which there's not always overlap there. Okay, thank you. All right, so I think we can close off.
Any more questions? Okay. So we want to thank our audience in Regina, as well as our audience here in Saskatchewan, and special thanks for Dr. Leaks for her presentation today.
Great. Thanks, everyone. Great, thanks.
I'm just like, okay, cool. Have a good weekend. You too. That is a really good question. I'm not sure.